If you direct your attention over here, this is what we often call degenerative aortic stenosis, especially in older adults. This is a slow fibrocalcific process that typically starts at the sinus of Valsalva and gradually creeps inward towards the cusp. The process usually affects patients 65 years and older. On echo, what you'll notice here is the classic appearance: thickened, stiff, heavily calcified cusps with reduced excursion. The second major cause is a congenital bicuspid aortic valve, usually with superimposed calcification. If you look closely at this clip, bicuspid valves can actually become stenotic even before calcification, especially in younger patients. Over time, calcification develops and becomes asymmetric. Direct your attention to the systolic opening, and you'll often see a classic football-shaped appearance along with a raphe. And anytime you identify a bicuspid valve, always remember to evaluate the ascending aorta. Symptoms typically present between the ages of 20 and 50 years old. And remember, bicuspid valves love company. They're commonly associated with aortic aneurysms, dissections, and coarctation of the aorta. So this should always trigger a more complete aortic evaluation. The third major cause is rheumatic aortic stenosis. If you shift your focus to this clip right here, rheumatic disease rarely affects just one valve. The hallmark finding is commissural fusion, which creates a triangular-shaped opening during systole. Unlike calcific disease, the cusps here become fibrotic and contracted. The restricted leaflet motion is due to fusion rather than calcium alone. And very importantly, if you see rheumatic involvement of the aortic valve, always evaluate the mitral valve because it is usually involved as well. This is one of the key ways we visually distinguish rheumatic aortic stenosis from calcific aortic stenosis in echo. This right here is a normal aortic valve. I just wanted to place all of them on the same slide so you'd be able to take a look and see how well the valve is opening when it's normal, differentiated from calcific and bicuspid, and also rheumatic. There are also less common causes of aortic outflow obstructions that you still need to recognize. Not all stenosis is valvular. You can have supravalvular aortic stenosis, which occurs above the valve, typically at the sinotubular junction. If you direct your attention here, this is the type of obstruction that is classically associated with Williams syndrome. Subvalvular aortic stenosis occurs below the valve in the LVOT, and it can be either fixed or dynamic. And remember, exactly where the obstruction is located matters because it directly affects diagnosis, management, and surgical planning. We cannot end this lecture without talking about the complications of aortic stenosis. One of the main ones you'll usually see is left ventricular hypertrophy, or what we call LVH. Here, you can see thickening of the left ventricular walls, which occurs when the heart has to work harder than normal. This occurs commonly with people who have aortic stenosis or high blood pressure. You can see left ventricular dilation, which I don't have up here, but what you'll normally see is enlargement of the left ventricular chamber, which can occur when the heart becomes weakened and stretches to maintain blood flow. Worst case scenario is possible heart failure. This is where the heart is unable to pump blood effectively to meet the body's needs. This is usually due to long-standing pressure or volume overload. As you do the exam to check for cusp separation, you're going to be utilizing M mode. So let's start with what a normal aortic valve looks like on M mode. If you look right here, you'll see the cusps opening widely and symmetrically during systole. The cusps move clearly away from each other, creating a large central opening. This wide separation tells us the valve is mobile and unobstructed. This right here is a normal aortic cusp separation. Now, compare that to the calcific or rheumatic aortic stenosis. If you focus on the cusps here, you'll notice they look thick, bright, and dense, which indicates calcification or fibrosis. During systole, the cusps do not open fully, and the distance between them is much smaller. This is called decreased aortic cusp separation, or decreased ACS. As stenosis becomes more severe, the separation continues to decrease. Finally, let's look at a stenotic bicuspid aortic valve on M mode. Notice here that the closure line is off-center or eccentric, instead of centrally located like the normal trileaflet valve. That eccentric closure line is a key cue that this valve has 2 cusps instead of 3. When stenosis develops, the cusps become thickened and restricted, and once again you'll see decreased aortic cusp separation. So remember, wide and symmetric opening is normal, reduced opening means stenosis, and an off-center closure line points you towards a bicuspid aortic valve. Finally, let's talk about treatment options for aortic stenosis. The doctor may order serial echoes. Serial echoes are when echocardiograms are repeated over time to watch how the heart changes. In aortic stenosis, this helps us see if the valve is becoming more narrowed, how the left ventricle is responding, and when the condition may be getting worse or needs surgical intervention or other types of treatment. AVR, or aortic valve replacement. This is an open heart surgery where a diseased aortic valve is removed and replaced with a new valve made of either metal or tissue. This surgery is used to treat severe aortic stenosis or regurgitation, and it helps improve blood flow, reduce symptoms, and protect the heart from long-term damage. Another thing they may do is a mini thoracotomy. This is a less invasive type of heart surgery that uses a small incision between the ribs instead of opening the entire breastbone. This approach is usually good for the patient because it results in less pain, faster healing, and quicker recovery, and it can be used for valve repair or valve replacement. One of the things you'll see a lot in your career is what we call a TAVR, which is a transcatheter aortic valve replacement. This is a minimally invasive procedure used to replace a narrowed aortic valve without open heart surgery. A new valve is delivered through a catheter, usually from an artery in the leg, and placed inside the old valve, pushing the diseased leaflets aside and restoring normal blood flow. TAVR allows for faster recovery and shorter hospital stays, especially in patients with severe aortic stenosis. If this helped you, subscribe so I can keep helping. Don't miss the next video.